So according to the Nordic therapy, the Nordic 2 version of the clinical trial, there's 159 patients in that clinical trial, and the median survival was 12.5 years. So great trial, and people get to live for more than 12 years. That's great. However, the chemotherapies are DNA breakers. They attack the tumor DNA, but at the same time, these intensive therapies, they also attack the normal human DNA. So 12.5% of the patients on that Nordic trial, which was treated this way, such as the patient we're referring to, 12% of them have another form of malignancy. We call it secondary malignancies. So although this is a very commonly used therapy, but everybody have to explain to the patient, yes, the median survival is over 12 years, but there's also another fatal complication that's potentially related to this therapy is the secondary malignancies, which means that we must improve on the current therapy. We cannot just use this therapy forever without improvement. And at MD Anderson, we did a clinical trial called the Window 2 clinical trial, which uses ibrutinib with rituximab to induce the complete remission, followed by only 4 cycles of hyperCVAD without any stem cell transplantation. And this therapy was presented at the American Society of Hematology in 2016. This updated data was again presented in June in Lugano malignant lymphoma meeting, another international lymphoma meeting in 2017. The overall response rate was 100% before chemotherapy. The CR rate was 90% before chemotherapy. So we do not need a lot of chemotherapy to get long-term survival, although I have to caution everybody that Window 2 clinical trial follow-up time is still short. So I would say that this patient were treated in the almost a standard care way, but if the patient present MD Anderson, I would put him into the Window clinical trial. I really think the most important therapy is the first therapy. So for the community, for the patient, you can tell them it's the first therapy. For the community, for the colleagues working oncology, we call it frontline therapy. Frontline therapy is the most important therapy in aggressive lymphoma. And this is especially true for mantle cell lymphoma. If you mess up the first line therapy and the frontline therapy, you would mess up a long-term remission. If you treat the patient with a good therapy, the patient can be therapy-free for 10 years. But if you treat a young patient, such as this case, with an inadequate therapy, such as R-CHOP for 6 cycles, such as R-bendamustine, those are only for the elderly people who could not tolerate this intensive therapy, such as stem cell transplantation. So the frontline therapy for young patient, young fit patient, has to have intensity. Why? Because as you can imagine, the tumor as an iceberg. You can see what's above the water with scans, blood tests, bone marrow examinations, but what below the water is even maybe account for 70 to 19% of tumor you cannot see. So if you shave it, use the superficial therapies, R-CHOP, R-bendamustine, you shape over what's above the water, the scans become negative, you think the patient is doing great, and shortly, after a year or two, the base grew up with a very aggressive. Those are no longer chemosensitive. They are very refractory to chemotherapy because of the first-line therapy, right? So you want the frontline intensity. What is frontline intensity? That means you have to use a high-powered chemotherapy, such as the Nordic therapy, all 8 cycles of hyperCVAD, to kill the tumor, to kill all the tumors above and below the deep water. Frontline intensity is the most important principle for newly diagnosed young patient with mantle cell lymphoma, such as this case. So we're talking about the frontline intensity that's associated with the overall survival, either with Nordic or hyperCVAD, over 10 years. But if you give the patient inadequate therapy, the survival only 3 to 5 years. It is heaven and earth. You cannot make that mistake. So for young, fit patient with newly diagnosed mantle cell lymphoma, please treat the patient either with a Nordic therapy or with 6 to 8 cycles hyper-CVAD. If you don't know how to do it, please refer that patient to a major referral center. And for all the academic colleagues, we need to make further improvement on these 2 therapies that's over 15 years old. Please refer that patient to a clinical trial with good, well-designed clinical trials such as the window trial.